All right, and welcome to the moment you've all been waiting for, and that's the answers to this chest X-ray conundrum. Remember, we try to use our A to F method, so let's get started. This first one is the 35-year-old female who has shortness of breath and cough. Now, when you look at this airway, it looks rather midline there, but if you look closely, it actually does get deviated toward the right. There's the right mainstem bronchus, left mainstem bronchus. B for bones, no fractures, no soft tissue swelling, no edema. C, cardiac. Well, you can't really evaluate the cardiac silhouette. You can see that the right looks okay, but the left is completely silhouetted here. So that leads us to our next area of evaluation, and that's the diaphragm. This hemidiaphragm is clear. This hemidiaphragm is nowhere to be found. So when it comes to E for effusions, we believe that there is definitely an effusion here on the left. Some telltale signs is first that blunting of the costophrenic angle, and then further in this upright film, this sort of meniscus sign. F for lung fields. When I look at these lung fields, are they clear? No, they are not. And what you actually see is, number one, a slightly dilated pulmonary artery here, and I'm sure you'd see the same thing over here if you could actually see it. But then you see these interstitial infiltrates kind of radiating from this pulmonary artery, at least on the right side, and a little bit on the left too. These hazy infiltrates. Lines, tubes, we don't have anything. So my final interpretation of this chest X-ray is bilateral interstitial infiltrates, most likely consistent with pulmonary edema, as well as a large left pleural effusion. Now, you may ask yourself, is this a transudative effusion or is this an exudative effusion? Remember, the difference between the two, transudative effusions are a result of increased hydrostatic pressure. So fluid is pushed out of the blood vessel. Exudative effusions, on the other hand, are due to inflammation. So you get these spaces in your endothelial cells, or at least between them, and that allows protein to leak out. And when protein leaks out, water is going to follow. And so in a transudative effusion, this is very much like a serous fluid. But in an exudative effusion, this is like pus or, just thick inflammatory fluid. So what kind of effusion is this one? I'll tell you, the only way to really tell is to do a thoracentesis. And we're going to talk about pleural diseases like effusions, but I would probably guess that this is likely transudative effusion. Reason being, I already have evidence of volume overload, right? Remember, those transudative effusions have increased hydrostatic pressure. So we're talking conditions like heart failure, renal failure, liver failure, something causing chronic pushing of fluid out of the vascular space. So because I already see that process happening in the lung field, why wouldn't it be happening in the pleural space as well? But again, the only definitive way to send that is to send that off and do some pleural studies. All right. Now we have this 78-year-old male who has acute onset shortness of breath and cough. Our airway is midline. There are no broken bones or subcutaneous emphysema, although you can't see distally here, but from what we can see, there's none. C, cardiac. When you actually look at this cardiac silhouette, it looks like it may be a little bit enlarged. Now, does this patient have cardiomegaly? Who knows, right? This may be an AP film, and so it may be difficult to truly say, but you can see if you were to sort of take this side of the heart, and plot it against the distance of the mediastinum, it's fairly large. D for diaphragms. So this hemidiaphragm is nice and sharp. This hemidiaphragm is also sharp. I'm going to say that there's no effusions there. So effusions, no. F, lung fields. Well, you have a lot of stuff going on here. So I see a lot of these kind of linear infiltrates, kind of lacy reticular pattern here. But when I look here specifically, this looks more like an alveolar process. And even kind of retrocardiac. I'm wondering if there's an alveolar process there as well. You see these sort of streakies here. So now you're like, well, what is it, dude? Is it interstitial or is it alveolar? And the answer is it can be both. Patients can have both. And that's really, really frustrating. So just to show you again, when you kind of look at all of these, they look like streaky in the interstitium moving away from the heart. But when you look here, you have this sort of alveolar looking process. And one of the telltale signs is, see that little hole there? There's one here too. What is that? Remember, that's an air bronchogram. So that is when you have so much schmutz in this alveolus that you actually start to highlight and outline the bronchus, the air inside of the bronchus itself. The last thing that we need to look at is lines, tubes, and devices. So this right here is a pacemaker. So this pacemaker body is implanted just above the chest wall, and the line of the pacemaker is tunneled through the subclavian vein. And now into that subclavian vein, it's going to be fed to feed the left heart, electricity. Now you may be asking yourself, how do you get from the vein to the left side of the heart? And the answer is actually something pretty creative. So what they do is they tunnel into the right atrium and they go through the coronary sinus, and they actually just seat the catheter in the coronary sinus into the left side of the heart so they can deliver electrical impulses. All right, final interpretation. Bilateral interstitial infiltrates with at least a right-sided alveolar infiltrate and a questionable left-sided alveolar infiltrate. How could you tell if there's also a left-sided alveolar infiltrate? You could get a lateral film, you could get a CT, and kind of differentiate. All right, moving on. Case number 3, I'm going to save you the gory details and show you this. Has a big heart, and this is actually a sign. In fact, this is the water bottle sign. What is that consistent with? Remember, that is a pericardial effusion. So here is your heart, and all of this is fluid. This is your pericardium here, also pericardium right there. So this is all pericardial fluid building up, pericardial effusion. This chest x-ray, I think, actually looks kind of funny because these lung fields appear over-penetrated to me. So they look like they're over-penetrated. But this thoracic spine here looks under-penetrated. Just rather interesting finding. But at any rate, water bottle sign. Case number 4 is a 23-year-old male who has blunt trauma to the chest. Let's start with A, airway. It is midline. B, bones. There is a rib fracture right here, and there's actually another rib fracture right here. Let me zoom in on those. So you can see this kind of step off right here in this line, rib fracture number 1, and you have another step off, rib fracture number 2 here. Now you may ask yourself, which rib is that? And remember, we have to count. This first rib kind of comes around like this. Here it is again on this side, which means that the second rib is right here, the third rib is here, 4, 5, 6, 7, 8, 9. So we have a rib fracture on rib 8, rib fracture on rib 9. Now there's also a rib fracture on 10. To be honest with you, the only reason I know that is because I read the answers. This would be very, very difficult to find in clinical practice because it's just hard to see. But all right, so rib fractures on ribs 8 and 9. Heart and mediastinum. So I don't see any cardiomegaly, but this mediastinum kind of looks off-center. It kind of looks pushed over this way. Indeed it is. So this is a deviated mediastinum, a shifted mediastinum to the left. D for diaphragms. This hemidiaphragm is nice and sharp. And you know what? The more that I look at this hemidiaphragm over here, I really agree that this is something. There's something going on in here. So this is the liver there, and this is a fluid level. At least it appears to be a fluid level. Now the question is this fluid level originating from the thorax or is it originating from the abdomen? And the answer to that question is, I don't know. Now, how could you differentiate? You could have the patient do a left lateral decubitus, which would probably be a bad idea in the setting of trauma. You could do a CT, which hopefully is happening, and you could do an ultrasound, like a fast exam, which should also hopefully be happening. And you just put your probe here, and you can see, is this fluid above the diaphragm or is it below the diaphragm? Okay. Now we move on to lung fields. So this is an expiratory film, as noted down here. So this is actually a normal appearing expiratory lung. You should have some level of haziness. But when you look over here, there is a complete absence of lung markings here and here. So you can kind of trace the lung markings as they stop. They're all there. And this is all pneumothorax. All of this space. All in here. Big pneumothorax. Where did that pneumo come from? It came from the fracture in rib 8 and the fracture in rib 9, blunt trauma to the chest. Final interpretation. This is a large right-sided pneumothorax with tension physiology, mediastinal shift to the left, and rib fractures on ribs 8 and 9. All right, 77-year-old male with a history of chronic cough. And let's start. Airway is midline. B bones, no fractures or anything like that. C heart, look at this little dinky heart. This is called a hanging heart sign. So hanging heart. And this is commonly seen in states of hyperinflation. So it's not that the heart is actually small. Not small. It's that the heart appears small relative to the big lung fields that you have. D, diaphragms. Do these diaphragms look pushed down to you? They look very low to me. So these diaphragms look like they're kind of shifted downward. Effusions. Now I don't see any effusions on this, but what do you notice about the film? The lower ends of the costophrenic angles are cut off. So you can't fully say that there's no effusion. F for lung fields. So these lung fields are relatively clear. These are all normal vascular markings here. These pulmonary arteries appear maybe slightly dilated, which could be consistent with pulmonary hypertension, which given this patient's history is not super unreasonable. Now these lung spaces are hyperinflated. You look how many ribs are involved. Look how these diaphragms are pushed down, and look at this hanging heart. So this is a hyperinflated lung, often seen in COPD, emphysema, maybe even chronic asthma or some other chronic obstructive process. Now, you may be inclined to just believe that these lungs are perfectly normal and everything is hunky-dory. But remember, you have to trace all of these lung tissues all the way out to the periphery. Because if you don't, you're going to miss this pneumothorax here. So you see lung marking, and all of a sudden they stop. In fact, they stop consistently right along this line. So this is an apical pneumothorax here. So, final interpretation. These are hyperinflated lungs with a left-sided, moderately sized pneumothorax in the apex. Case number 6, this is a 55-year-old female with hemoptysis. Airway is midline. Bones, nothing broken. Cardiac silhouette is normal. Diaphragms, costophrenic angles are both clear. No effusion. Lung fields. So this. Look at that. And a little bit of haziness up here. And these are just normal lung markings. Okay. So we can see that there's a mass, some sort of thoracic mass here. Do you see any calcifications? Do you see any bright white? I don't. This is rib coming through here. So this is very concerning for malignancy. And this may also be a mass here. So, final interpretation. there is a large round mass in the right, which lobe? Most likely the upper lobe. Here's that horizontal fissure here. So I'm going to call this a right upper lobe mass with a questionable second right upper lobe mass. Given her history of hemoptysis, you're starting to be very concerned that this is lung cancer. So what would my next steps be? I'd probably get a CT next. I would also get a bronch finished, a bronchoscopy. And this is going to tell you, is this mass extrabronchial? So it's in the lung parenchyma itself, outside of the bronchus. Or is it endobronchial? Is this a big endobronchial mass? Given her history of hemoptysis, there is at least some sort of bronchial involvement, whether that's this endobronchial mass or this extrabronchial mass kind of eroding into the bronchus itself, causing blood to be spewed out her airway. So, right upper lobe mass. All right, case number 7 is this 19-year-old female with fevers and cough and wheeze for 2 weeks. Airway is midline. No bone fractures or anything of that nature. Heart, nice and small. D, diaphragms, nice and clear costophrenic angle here. This one is not clear. You can see there's haziness there. Now, if this haziness is just infiltrate versus effusion, that's up for debate, but you do not have a clear costophrenic angle. So effusion, questionable, maybe. Lung fields. So we have these sort of lacy reticular infiltrates coming out here. Look like little lace. It looks like we have an alveolar process here in the left lower lobe. There's a little air bronchogram there. No lines, tubes, or devices. So, final interpretation. This is a patient with bilateral interstitial infiltrates with a left lower lobe alveolar infiltrate. So, what is going on? Well, given her history of fevers, cough, wheeze for 2 weeks, this looks very much like an atypical pneumonia pattern. Atypical pneumonia, which we'll learn about. All right. And I apologize. I realize that there's 2 case number 8s. So this is case number 8 and number 1. This is a 58-year-old female with fevers, cough, shortness of breath for 4 days. So A for airway. Airway is relatively midline. This film looks like it's a little bit rotated. No bone fractures or anything of that nature. C, cardiac silhouette, is maybe questionably large. D for diaphragms. These costophrenic angles are both nice and sharp. E, effusions, no. F, lung fields. So we have some sort of hazy interstitial infiltrates here. You can actually see some infiltrate tracking along this horizontal fissure, a little bit more here. But then we have this dense alveolar process here. What is this? That's that air bronchogram. So there's an alveolar infiltrate here. Which lobe is this in? Well, we have silhouetting. So this is right ventricle. This is left ventricle. Left atrium. Right atrium is here. So what is it silhouetting? Well, it's silhouetting the right atrium, and it's sparing the diaphragm. And not only that, you can see this horizontal fissure. So this is a right middle lobe infiltrate. So final interpretation, we have bilateral interstitial infiltrates with a right middle lobe consolidation. Right there. Case number 8, number 2. We have an 88-year-old female who has chest pain, shortness of breath, and tachypnea for 2 days. All right. So airway is midline. B bones, no fractures or anything of that nature. Heart looks good to me. D for diaphragms, nice and sharp here. A little bit less sharp here. I'm not super convinced that this is an effusion, but it's less sharp, and so maybe it's a little tiny baby one. Lung fields. So we actually also have some interstitial processes going on here and here as well. And it looks like we have sort of an alveolar process right here. You can tell you have your air bronchogram again. Maybe another small one here. Another little air bronchogram there. Lines, tubes, and devices, we don't have any. So, final interpretation of this image, we have bilateral interstitial infiltrates with a alveolar infiltrate of the left upper lobe. Why do we say left upper lobe? Well, we're silhouetting sort of this left atrium / aortic knob and sparing all of this. Now, to definitively say, yes, this is left upper lobe with 0 left lower lobe involvement, of course, we'd probably need a lateral film, but this is pretty convincingly left upper lobe. Case number 9. So this is a 36-year-old male with undifferentiated tachypnea and diarrhea. So airway is midline. No bone fractures or anything of that nature. Heart looks good. Diaphragms, sharp costophrenic angle, sharp costophrenic angle. We got something funny here. It looks like air. It looks like there's air here too. But what is the air here? Well, that's normal. That's lunch. It's okay if you have air in your stomach. That makes me happy. But when you look over here, this is liver, right? Air is not okay. So this is a problem. So here's your diaphragm right there, and you have this air collection here. So that is a pneumoperitoneum. Maybe a portion of the colon perforated and let air leak out, and it all floats up to where it's most superior point and collects right here under the diaphragm. So we have free air in the belly. No effusions though, so great. And then F, lung fields. So we again have these lacy interstitial reticular infiltrates here. No lines, tubes, or devices. So final interpretation, we have bilateral interstitial infiltrates as well as free air in the abdomen. Case number 10. 56-year-old male with chronic hypoxemic respiratory failure. Airway, what is this? Well, it's a tracheostomy tube. So that trach is surgically put in, and it sort of looks like this. It has a hole in it, and there's a tube that comes out, and that tube sometimes has a balloon on the end that will fill up, and the carina is somewhere down here, so it actually sits in the trach. This is a trachea. So you can actually ventilate through this trachea and into the lungs. So this patient can breathe spontaneously through this trachea, or this patient can be put on what we call a trach collar, which is kind of like a face mask for a trach, or they can be put on an actual ventilator through this trach. So why does this patient have a tracheostomy? Well, because he has chronic hypoxemic respiratory failure. Maybe he's in and out of the hospital and has a lot of oxygen requirements, maybe frequently requires mechanical ventilation, that kind of stuff. B, bones, no fractures or anything like that. C, cardiac, looks good to me, not very big. Costophrenic angles are nice and sharp, so no effusion. Lung fields. So we have these sort of nodular nodular interstitial infiltrates here. These are all interstitial and yucky looking. We also have some sort of actual real interstitial infiltrates. Here's that horizontal fissure again. So you can see here there's fluid all in that horizontal fissure right there. Here's some more linear infiltrates. Another one there. There. Some more here. So these are all interstitial infiltrates. Look nice and nasty. So final interpretation. This is a patient with bilateral nodular interstitial infiltrates with a tracheostomy in situ. And actually, this is a demonstrated patient with interstitial lung disease. This is actual ILD. All right. Case number 11 is a 3-year-old female who has cough and shortness of breath for 3 days. So in this 3-year-old female, these lung markings probably more likely represent poor inspiratory effort as opposed to true infiltrate. And would I ask you to differentiate that? Probably not, but just historically speaking, this little girl is probably not able to be coached to take a really big deep breath. But that said, the airway's midline, but we have this big thing in it. And is this actually in the airway? Well, first of all, what is it? It really looks like a button battery to me. You can kind of see these edges around here. So this looks like it's a button battery. And if this button battery was in this tiny little airway, you'd expect the patient to present with stridor, not necessarily just cough, shortness, real, true shortness of breath and distress. Like, she probably wouldn't be able to tolerate that for 2 days. So already clinically, I'm thinking it's probably not so much in the airway. But let's get a lateral film just to make sure. So you can actually see that the airway is clear. And this button battery is actually in the esophagus. So she needs an EGD to remove this button battery, especially so you don't get a tracheoesophageal fistula, a communication between the trach and the esophagus right there. All right, last case. This is a lateral film. So post-op patient who's day 0 from hernia repair. So A for airway. Airway is here. It's patent. Can you tell if it's shifted to the left or to the right? No, not on this lateral film. B for bones, no fractures or anything of that nature. C, cardiac, no cardiomegaly that we can appreciate. You can see that aorta here. D, diaphragms are nice and clear. Costophrenic angles are sharp. There's no effusion. And then lung fields. So most of the lung field is pretty clear. This film looks like it has some penetration issues. You can't see all the lung markings down here, and you can't see the IVC. However, you have this sort of wedge-shaped infiltrate here. Now, to be honest with you, this infiltrate could be anything. It could just be collapsed lung. It could be mass causing collapse. It could be pneumonia. It could be pus. It could be anything. So it's really hard to say from an image standpoint what this is, but you have this sort of wedge-shaped appearance here. Remember from our anatomy, the right atrium is about in this location, and that means that this wedge-shaped density is in the right middle lobe. So what is it? Clinically speaking, this patient is without cough. She's without shortness of breath, at least from what we can appreciate here. She's fairly young, and she just had surgery. So if you think about it, what do you think your ventilation is like after surgery? Well, it's probably not very good. You're waking up from sedation. You are on pain medication. And further, she just had a hernia repair. So do you think it's really comfortable for her to take deep breaths into her belly? Probably not. So this patient isn't taking very deep breaths, and one of the most common things that happen post-operatively is called atelectasis.